All right, thank you for the kind introduction. And thank you for welcoming me into your community. I have learned so much from the other speakers and from all of you. It's been great to hear your stories, and it's really an honor and a privilege to be able to be part of this. So thanks for this opportunity, and hopefully some of what I share with you about sleep medicine today will be helpful to you. My disclosures include my funding source. Part of my fellowship is funded by a sleep and genetics research grant, and I'm a sleep physician. I'm not a neurologist, so this presentation will be really focused from the lens of sleep. My residency background is in internal medicine and pediatrics, so I'm interested in taking care of children with sleep disorders, and I've gone back to do another fellowship in pulmonary medicine, so I'll be focusing this presentation also on airway clearance in the lungs as well. I'm going to start off the presentation with a story of my pulmonary call. When I was on call a few weeks ago, I got a page at around 2 or 3 a.m. from a parent with Lennox-Gastaut Syndrome. Their call really was about sleep and not their child's lungs, but as we know, sleep is impacted by many organ systems. The parent, when I spoke to her, it seemed was just really frustrated by her child's sleep. She herself hadn't had good sleep in months, and her child's sleep was just getting worse and worse with insomnia, sleep disordered breathing, and I think she just really needed someone to talk to, and luckily I was able to provide her with some pointers. I think this parent is not alone, and that's why I'm grateful to be able to talk to you about sleep today. Today we'll talk about what sleep problems even are in children. We'll talk about how common sleep problems are in children with Lennox-Gastaut syndrome. We'll talk about some of the causes, the consequences, when to ask for help. What are some ways to diagnose sleep problems? What are some treatment options? And then lastly, we'll talk about some next steps. How common are sleep problems in Lennox-Gastaut syndrome? Okay, so in the room, if your child has a sleep problem, can you please stand up or raise your hand? All right, almost everyone, and there's some lucky ones with no sleep problems, which is great. If your child has a sleep problem that's being treated right now, can you please stand up or raise your hand? So there are a lot fewer people whose sleep problems are actually being treated compared to those who are actually experiencing sleep difficulties. How often do sleep problems in children with Lennox-Gastaut syndrome affect the family? So if you, a caregiver or a sibling, have a sleep problem as a result of the child with Lennox-Gastaut syndrome, can you stand up or raise your hand? Okay, so basically it seems like most caregivers are experiencing some sort of sleep problem as well. And that's basically, I would say, the state of the art in terms of characterization of sleep problems in children with Lennox-Gastaut syndrome. We know this is a big problem, and we know that there are many different types of sleep problems as well in children with Lennox-Gastaut syndrome, but the literature actually focuses a lot on the EEG findings and the sleep study findings, and not so much in identifying exactly how common the sleep problems are and exactly what those sleep problems are. And in order to be able to figure out if we can treat these sleep problems and what that outcome will be, we need to first have that basic fundamental of how common the sleep problems are and what the sleep problems are. And then just in general, before we start talking about sleep problems, we should really all have a shared understanding of what are some sleep disorders in general. So this slide just is a very general slide about pediatric sleep problems, and really also is relevant to adults as well. So the cartoon, you can see, has various organs, including the brain and the head, and the lungs and the chest and the heart. And there's always a debate amongst sleep doctors who are pulmonologists versus neurologists, which I said I'm not, but I even though I'm a pulmonologist in training, and most pulmonologists think like sleep is all about the lungs, we have to give people CPAP and treat the lung disorder, I do admit most of sleep is generated from the brain, and we have to target what's going on in the brain first to be able to make a global impact in a person's sleep. So there's the brain, the lungs, like I said, the chest wall, and so just keep this in mind when we talk about the different sleep disorders. The first one I'm going to mention is sleep apnea. And so what sleep apnea is, it's either a partial or full closure at the level of the upper airway, and that results in either the brain waking up very briefly, the person's not typically aware that the brain is even waking up, or it can result in an oxygen desaturation. And so that can be due to a structural issue, and that's obstructive sleep apnea, or it can happen when the brain signal to the body is not really working, or the body signal to the brain telling the brain to breathe is somehow disrupted as well. And that can be due to many reasons, such as epilepsy, but it can also be due to liver issues, heart issues, and that won't be the focus of the talk today, though. Another very common sleep disorder is hypoventilation, which is a disorder of gas exchange. So as you know, when we breathe in, we're breathing in oxygen from the air, and that's going to the lungs, and that is exchanged with carbon dioxide, which is a waste material, and then that gets exhaled. And if there's an issue with that, that can cause excessive daytime sleepiness, pulmonary hypertension, headaches, other mood-related issues as well. Insomnia. Insomnia is the inability to, or difficulty with falling asleep or staying asleep, and that can be due to many reasons as well. Untreated sleep disorders such as sleep disordered breathing can cause insomnia. Inability of the brain to calm down or fall asleep, that can cause insomnia. There can be behavioral reasons for insomnia as well. There are circadian rhythm disorders. So your community is probably quite familiar with circadian rhythm disorders. That includes an inability to fall asleep basically at the conventional time that we would expect. So falling asleep way too late or way too early. Basically, our body clock, there's a disorder in the central body clock. And then restless leg syndrome is also another common sleep disorder in children. The actual cause of restless leg syndrome is unknown. What that is this overwhelming urge to move the legs or the limbs closer to bedtime typically. It can also happen throughout the day, but that's also in alignment with our body clock. So we talked about what some sleep disorders are. We talked about how we're not quite sure, I guess in a scientific way, what sleep disorders are most common in Lennox-Gastaut syndrome and how common they are. But we do have the good fortune of being able to use data collected by patient networks and research networks such as the Rare Epilepsy Network. And as you know, the Rare Epilepsy Network is a network of organizations that study and advocate for rare epilepsies. And they collected patient-centered data on almost 2,000, I believe, caregivers and patients, and that very thoughtfully included sleep data. So we were lucky to be able to use their data to answer the following questions. What proportion of children with early life epilepsies have a reported sleep concern? Which early life epilepsies are most commonly associated with sleep concerns? What are the most commonly reported sleep concerns? And is there an association between nocturnal seizures and sleep concerns? We used information from 356 children. Half were above the age of 5, and half were less than 5 years old. Over half were girls, most were white, and a little over half endorsed a sleep concern. How common are sleep concerns in children with early life epilepsies, and which ones are the most common? As you can see on the top row, where it says presence of sleep concern, 53% of the caregivers endorsed a sleep concern. And then we wanted to see which ones are the most common. The Rare Epilepsy Network asked a series of closed-ended questions about sleep disorders and sleep concerns. And they found, or their data suggested that frequent nighttime awakenings, difficulty falling asleep, and very restless sleep were the most common sleep concerns. I thought that this was a very interesting finding because these symptoms can be a symptom of multiple things. It can be a symptom of something like pain, or untreated sleep apnea, or seizures. The other interesting thing was that these are the same sleep concerns that are most commonly endorsed in typically developing children, at least till the age of 3. That doesn't mean the reason for those symptoms of frequent nighttime awakenings, let's say, is the same, but these are very similar symptoms that happen in typically developing children as well. Sleep concerns are common regardless of early life epilepsy syndrome. On the left-hand side, you see that there are a multitude of epilepsy syndromes or types that were included in the survey. And actually, the reason that we think that the REN data is compelling, even for this talk, is that it included some epilepsy types that can progress to Lennox-Gastaut syndrome. You'll see that anywhere between 30% in Ohtahara syndrome and 84% in Dupe 15q syndrome of children had a sleep concern that was endorsed. And when we did some statistical analyses, we found that regardless of epilepsy syndrome type, there was a sleep concern endorsed. So basically, most children with epilepsy will have a sleep concern that the parent is concerned about. Sleep problems not only persist, but they may be more prevalent with increased age. Here in this graph, we see that sleep problems are more endorsed as age increases. And that's interesting because typically after around age 3, in a typically developing child, sleep concerns will start to taper off. And here we see that not only do they not taper off, but the prevalence actually increases. And this is not driven by nocturnal seizures. So unlike the previous slide where we saw that the prevalence of sleep concerns kept increasing, see that overall the prevalence of nocturnal seizures is about the same. So it's not that it's the seizures that keep waking up the child or disturbing the child's sleep. To summarize, sleep problems are very common. They persist through childhood in early life epilepsies, and they are not only explained by nocturnal seizures. I'm going to shift gears and tell you about a patient of mine with Lennox-Gastaut syndrome. She's a 3-year-old girl with multiple sleep-wake periods. And then just for your interest as well, I think it's interesting, so I hope you think it's interesting. I'm going to run through what we, as sleep doctors, might typically ask you about when we ask about a sleep history, and this is part of just the standard practice in learning more about the sleep schedule of children. So we'll ask about bedtime, and that's when the child goes to bed and actually goes to bed, and that's the intended sleep time. Sleep onset latency basically means how long it takes to fall asleep. And then nighttime awakenings, or frequency of nighttime awakenings, is how often the child will wake up between the time they go to bed and they wake up in the morning. And then from using that information, we can get an estimate of how much they're actually awake in the middle of the night. What is the child's wake time? How many naps do they take? How long are those naps? And then using that information, in sum, we can get an estimate of the total sleep time of a child. So this patient of mine, she would go to bed anywhere like between 11 p.m. to 2 a.m., typically around midnight, and then she would wake up at 4 a.m. The amount of time it took for her to fall asleep would really vary depending on the day. Sometimes it was just half an hour, and sometimes it was longer. She would have a discrete sleep period between the time she went to bed and 4 a.m. She'd wake up at 4 a.m., and her parents said that's when party time happened. So she would wake up, insist on using her iPad. She has favorite videos that she must watch at that time. If she didn't have those videos, she would scream. And basically, this was a time of high level of activity for the patient. She would be up for a few hours and then go back to sleep. And then she would sleep until 11 a.m. She would nap for about an hour early in the morning. And if you look at the actual amount of time she was sleeping, it was 10 hours, which is almost the appropriate amount of time for a child age. But clearly that doesn't mean that the sleep was necessarily of good quality. And clearly there are probably a few different things going on with her. And so while we talk about why do people with Lennox-Gastaut syndrome have so much trouble with sleep, I want to just refer back to that cartoon where we think about the different organ systems and how they might be affecting sleep. There can be increased cortical arousal. We know that people with insomnia in general, with no other neurologic disorder, have increased brainwave activity, and that's seen on sleep studies standardly. It can be due to a circadian rhythm disorder. We know that even though there is limited literature on epilepsy and melatonin, we know there's a lot of literature in the autism population, and many children with autism also have epilepsy, and they have been shown to have reduced amount of melatonin. And melatonin is one of the hormones that our pineal gland in the brain produces, which affects the body clock. And then there's also a dysregulation in the clock genes themselves, and that again is being controlled by our central body clock. And interestingly, the clock genes lead to the creation of transcription factors, which control genes all within the different organs of our bodies. So really that central body clock is responsible for a lot of our health. We talked about sleep-disordered breathing, again, structural causes in the upper airway, which can cause sleep apnea, and then also impaired airway clearance as well. I've had a patient who had issues with secretions, difficulty controlling saliva, a weak cough, so a lot of mucus production and retention in the chest. And of course, just imagine if your airways are plugged up with saliva and mucus, it's hard for the air to actually get out, and that can contribute to obstruction. Hypoventilation, again, the impairment in gas exchange, and so if a child has weak muscles, for example with cerebral palsy, that impairs the actual pump effort itself from pushing air out and getting the oxygen back in. Medications can also affect sleep, and there can be behavioral sleep disorders, which are especially common in children with chronic illnesses such as Lennox-Gastaut Syndrome. We've talked a lot yesterday about sleep trackers or concern for SUDEP during sleep, and many parents sleep in the same room as their child or even the same bed, but in so doing that develops an association between sleep and that specific parent. And so if a child wakes up, they don't see that parent, they don't know how to fall asleep without that parent being there. What are some consequences of abnormal sleep? There can be an effect on brain maturation, seizures, memory and learning, the heart and metabolism, and quality of life and behavior. We all know that if we don't get enough sleep or if we don't get good quality sleep, our mood isn't good, we just don't function as well throughout the day. And then there can be an impact on siblings. Siblings themselves can develop behavioral insomnia, and many siblings feel the responsibility to monitor the safety of the child with Lennox-Gastaut syndrome. And then there's an effect on caregivers. I'm going to talk about More Rare Epilepsy Network data, where the goal of this study that I'm showing you was to look at the impact of pediatric sleep disturbance and nighttime seizure monitoring on caregivers of children with rare epilepsies, basically. They found that if the child had difficulty falling asleep, excessive daytime sleepiness, frequent nighttime awakenings, and very restless sleep, this was associated with caregiver fatigue, sleep-related disturbance, and sleep impairment. They also found that risk factors for caregiver anxiety and depression were caregiver fatigue and poor sleep quality, and they found that some protective factors were companionship and higher cognition scores. To summarize, caregivers' sleep and mental health can be affected by their child's sleep disorder, and it's important to ensure support systems are in place for the caregiver and their family. So now that we know that sleep in children with Lennox-Gastaut is a problem and it can affect the whole family, when should you ask for help? Caregivers, you should consider bringing up the concerns when they come up. You can ask the primary physician, your child's neurologist, your child's pulmonologist. Anyone who's in your child's care team really can be an asset to you in directing you to the right resources. And don't wait until being frustrated for a long time, like that patient who paged at 3 a.m. She was really at her wit's end, and we can intervene earlier. And then healthcare workers or anyone else in the care team, just be aware of signs of sleep, disordered sleep, such as snoring, apneas, which is a cessation in breathing, insomnia, a lot of excessive daytime sleepiness, circadian rhythm issues, and just in the back of your mind, identify the resources that you'll use to assist in the patient's sleep management. So now you know when to ask for help. What will you do? What happens once you ask for help? Well, how do we diagnose sleep problems? You might be familiar in the right upper hand corner with a sleep study, and certainly the EEG portion on the scalp. Here you see scalp leads to measure sleep. There are effort bands on the chest and the abdomen, and those are measuring the effort of breathing. There's a pulse ox, which is looking at heart rate and oxygen saturation. There's a one-lead EKG, which it's a rudimentary look at the heart rhythms that are associated with whatever's going on in the child's sleep. And that's called a polysomnogram. At the left upper hand corner is a sleep log, so very similar to the seizure logs that we looked at yesterday. And basically, in this example, you would color in the box where the child is sleeping. And then there's more modern versions in a multitude of sleep apps. And then on the bottom of the slide is a actigraph, which is a medical grade sleep tracker, essentially. There's a accelerometer, a position monitor. It also senses light, and through a proprietary algorithm is able to basically suggest when a person is sleeping or not. What are some treatment options? I want to direct you to this website, which is a great patient resource, and then again think about the different organs involved in sleep as we talk about the options. Positive airway pressure is an option, so basically a machine will pump pressurized air through a tube, through a mask that stents the airway open. That's the most basic form. And then if there's an issue with ventilation, which is the exchange of oxygen and carbon dioxide, that machine can actually have different settings during inhalation and exhalation. Supplemental oxygen is an option. Airway clearance is also another option. The right side of the slide, we see that the child has a mask which is administering a nebulized medication. So there's some medications such as albuterol or ipratropium that either dry out the secretions or actually relax the airways so secretions can be mobilized, and that's a great way to have some good airway clearance going on. We can actually dry out the secretions at the mouth itself. So this is an example of sublingual atropine, where if you don't want to have an inhaled solution and you just need something quick acting and you know the secretions are mainly coming from the mouth, you can use that. A chest vest is also helpful for mobilizing secretions. And basically it shakes the chest and really mechanically gets the mucus and the saliva to come out, and it makes it easier for a child to cough out those secretions. And then for children with neuromuscular weakness who have a weak cough, there's a machine called a cough assist, which also looks, I guess, similar to the CPAP or BiPAP that I showed you, but basically it pushes air in and then quickly has some negative pressure as well that induces a cough. So these are just few of the many options. There's surgical options. For sleep apnea, the most common treatment in children is removal of the adenoids and tonsils. For very severe cases, we can use a tracheostomy, which is basically a tube in the airway that keeps it open and relieves the obstruction. And then for children who have obstruction mainly in the upper airway, like the nasopharynx, we can use a nasopharyngeal airway, and that's a relatively new treatment. There are many medications that can be used to treat insomnia and circadian rhythm disorders, and there are actually some medications which are in trials for treatment of sleep apnea as well in adults. Melatonin can be used for treatment of both insomnia and circadian rhythm disorders, and again, that's the hormone that our own brain produces. Clonidine can be used to induce sleep. Doxepin, which is an antidepressant in lower doses, can be used to induce sleep. Anti-seizure medications, when they're thoughtfully, the dosing time is thoughtfully prescribed, that can either make sleep better or worse. Gabapentin also stabilizes the brain and induces sleep. And then supplemental iron is used for restless leg syndrome. There are some behavioral sleep medicine options. These are just a few of many. Things like a star chart, for example, can lead to positive reinforcement techniques. And then for people who are not able to comprehend or engage with delayed gratification. There are classical conditioning techniques as well. For example, this is a good morning light, the light where the toy is in the background, and basically we're developing those associations between a particular light or a particular sound and the initiation of sleep. And that even works with infants. So what are some next steps? Clearly, we talked about many treatments, and again, there's so many reasons why a person can have a particular sleep disorder, and that thing that we actually see, that's the phenotype. But we all know that just like every epilepsy is different, every child is different, there are also many unique and specific causes for those sleep disorders, and that's what we call the endotype, and we need to learn more, take a step back even further and learn about the genotypes and really understand at all these different levels what exactly is causing children with Lennox-Gastaut syndrome to have these sleep disorders. And if we have that very precise understanding, we can develop, hopefully, some tools to treat sleep disorders in children with Lennox-Gastaut syndrome. So to conclude, a sleep evaluation should be a routine part of epilepsy management. Caregivers and family members should be screened for sleep disorders, and we need more research. What is normal sleep in Lennox-Gastaut syndrome? Is sleep a modifiable risk factor for children with Lennox-Gastaut syndrome? And if so, which sleep disorders? And are there gene or subtype specific treatments for children with Lennox-Gastaut syndrome? And most importantly, what are your priorities? Again, I just feel so privileged and honored to be here to hear about what you all have to say about your children and their sleep. And it's very important to listen to families to learn more about what directions we need to take. And then thank you for your attention, and thank you to my mentorship team, without whom I wouldn't be here talking to you today.
We have time for questions. If you have a question, please raise your hand. We'll get you a mic. And I'm not over here, checking my email while I'm up here. We actually have our virtual audience at home. And we do have one question already. The question is for kids who have LGS that won't comply with CPAP or BiPAP, are there alternatives for them that are in existence? So they can't behaviorally, or they have sensory issues or behavioral issues that would limit that.
That's a great question. I think it depends on the reason for the sleep apnea. There are some surgical options. We talked about adenotonsillectomy, but there are other surgeries as well, such as debulking of the tongue, for example, which increases the space between the back of the throat and the mouth. There are behavioral options. Positional options, that one is hard, I think, for any child, but sometimes sleep apnea is worse in one position versus the other. But I would say in that situation, potentially the more effective course would be a surgical option.
I want you as my sleep doctor.
Oh, I would love to be.
Right? I learned more in the last 20 minutes than I've learned from sleep doctors in a while. So I know we have some questions. Whoever has the mic, just start talking.
I have a mic.
Oh, okay.
Thank you.
All right. Talking over here first.
Thank you for being here. So my daughter was having clusters of tonic-clonic seizures at night, and of course, her sleeping wasn't that good. And so one of the things that we did to try to handle the situation was to crank up the nighttime settings of her VNS. Oh. And soon after we did that, she started snoring, and then so we did a sleep study, and what we found out is when the VNS was on the first half of the night, she stopped breathing 6 times, and that's when the settings, her VNS was stimulating. In the second half of the night, they turned off her VNS, and she was fine, and she slept through. So have you seen this kind of thing in this population where the VNS causes sleep apnea?
Yes, that's a common side effect of vagal nerve stimulation. So the vagal nerve also impacts the smooth muscles that support the airway, and some other muscles in the upper airway. So it's a known side effect of vagal nerve stimulation is sleep apnea. And so the neurologist they will typically pay very close attention to that side effect and work with a sleep doctor to see if there's sleep apnea that needs to be treated. And we actually do see that on the polysomnogram or the sleep study as well. We can clearly see the decrease in airflow sometimes in children who have vagal nerve stimulation.
Hello.
Next question.
My son, Aiden, he has, I guess, non-diagnosed sleep apnea. We recently saw an ENT specialist, and he has horrible snoring. He's had that for a long time. A surgery option that they gave us is and I might be saying it wrong, a turbinate reduction in the nose, so that is that the correct medical term, the turbinates in the nose? So like, if everyone's seen like a cross-sectional anatomy of a nose where they have like the little swirlies in the nose, it's like really inflamed. So he's gonna have a turbinate reduction next month, and that's supposedly supposed to help with the snoring because he has seizures while he's sleeping. So we're just kind of thinking that like once he goes into that REM sleep, that's when he kind of kicks into a seizure. So we're hoping that with the reduction of the turbinates, that that's what they're telling me, is that they're going to reduce his snoring and hopefully, reduce seizure activity as well. Have you seen any success with that, or are you familiar with that sort of surgery?
I personally have not had a patient with a turbinate reduction surgery, but I don't see why that wouldn't be helpful. And children with, especially syndromic children, can have multi-site obstruction. So I don't know if your son had something called a drug-induced sleep endoscopy, where basically under anesthesia, you can do an endoscope, so put a flexible camera through the nose, up the upper airway, and you can actually see the sites of collapse. And that is oftentimes how the ear, nose, and throat surgeon will determine where to do the surgery. So I'm personally not familiar with a patient who's had that, but I don't see why that wouldn't work, especially if that's where they saw the collapse.
I appreciate you. Thank you.
Yep, thank you.
We have one more question from online. So do you have any leads on finding doctors or research on those researchers who are familiar with MCAS or mast cell issues? I guess there's sleeping is made difficult because of these mast cells issues and the drug combination that this person on, which is Klonopin and Ambien. And so they're wondering if you know, like, what's the best strategy for going out and finding someone with a very specific specialty on sleep? I mean, besides you, who needs to move to San Diego now, so hurry up.
Yeah, okay. So that's an interesting question. So I would say the AASM.org, so American Academy of Sleep Medicine, they have a provider search function, and so you can find local people. But what I do, even for, say, if a friend says, oh, in the medical community, if you're in healthcare, now all your friends and family are asking, oh, I know someone with this random disease, can you help me or find a doctor who has that? And you're like, no, I don't even know what that is. But what I do typically is I'll Google that disease and look for people's research in that particular disease and see if they're local. And typically people who do research in a particular condition are really good at treating that condition too, if they are also physicians. And that strategy has worked out really well for answering all questions like that. But I would say the AASM.org website has a really great provider search function, and you can narrow that down by geography. So say if you found a list of people, and then in your other search of the disorder, you found a list of people and something aligns, then that would be the next step, I would say.
Great. Well, let's give a round of applause, Dr. Gupta. Thank you. That was fabulous. That was fabulous.